Okay, so good morning, everyone. Thank you to the presenters that have gone before me, Professor Njenga, Professor Haman, Professor Twoli, Dr. Koba, and there are 100 plus participants who are here with us. Thank you so much for joining us. I will be presenting on ensuring the continuity of services for people who use drugs amidst the COVID-19 pandemic. And this is based on our experience managing 2 clinics in Nairobi that are providing services for over 1,000 people who use drugs. So just to give you an overview of what we are dealing with, we work with people who use opiates. And when you look at the statistics globally, opiates actually cause the highest level of harm compared to other drug use. And it actually accounts for the highest number of healthy years lost. And this is as per the World Drug Report for 2018. When you look at some of the effects that opioid use has, it's been associated with very high levels of comorbid mental illness, as high as 40 to 60% prevalence. It has been associated with very high risk exposure to transmission of infectious diseases such as HIV and hepatitis, as well as sexually transmitted disease. And this is because of the nature of drug use. And the HIV prevalence stands as high as 18% globally, and with 52% prevalence of hepatitis C as a result of injecting drug use specifically. When you look at even psychosocial outcomes, there are a lot of persons who use drugs who have unstable housing and very high levels of incarceration or legal problems, which stands as high as 52%. So when you apply opioid substitution therapy, the objective is supposed to be twofold. One, you're supposed to reduce the harm that is associated with the high-risk drug use, but you're also supposed to provide an intervention, an addiction management intervention for people who have opioid use disorder. So when you look at it from the harm reduction perspective, we are usually working with what we call a comprehensive package of services, which provides about 10 interventions. So initially, the WHO, UNODC, and UNAIDS came up with a package of 9 interventions to provide harm reduction services for people, specifically people who inject drugs. And they identified the first 4. So the first 4 that are in red: needle and syringe exchange, opioid substitution therapy, HIV testing and counseling, and antiretroviral treatment. Those were identified as what we call high impact strategies. And the study saw that if you're able to scale that up to at least 70%, 80% coverage, then you will not only reduce HIV infection, but you'll actually reduce the infection curve. So any country that is trying to implement harm reduction, if they're unable to provide the 10 interventions, then they should be well placed to provide the first 4. So initially, overdose prevention and management was not considered an intervention. However, it was added. So when you look at this from an addiction perspective, if you're able to provide needles and syringes, if you're able to provide opioid substitution therapy and have a system of preventing overdose, then you'll be able to have a great start at managing opioid use disorder. So if we look at the statistics in Kenya, initially there was a large estimate that was proposed by the CDC of about 48,000 people who use drugs. So this is an inclusion of people who inject and people who smoke. In 2013, the National AIDS Control Council established a point estimate of about 18,327 people who inject specifically. And the lion's share of these are actually located in Mombasa and Nairobi, with Mombasa, of course, being the largest hub because of the drug trafficking route. Then when you looked at the Nairobi estimate specifically, the MAPS estimate that was done in 2013 identified a point estimate of about 6,216 people who inject drugs, specifically in Nairobi. So right now we have done a more recent population size estimate that was done in between 2018 and 2019, and the number seems to have declined. So what we are awaiting validation is whether we will proceed with 5,024 people who inject drugs in Nairobi. So nonetheless, the number is above 5,000. We have, as of 2013, we had an identified HIV prevalence of 18.7% amongst people who inject drugs. We are yet to obtain the most recent documentation of this, especially in light of the fact that we've seen the epidemic curve has declined in the general population. We, however, still suspect that this is higher. At the moment, our clinics have a 9% prevalence, which is still twice as high as the general population. And of course, we had a study that showed a 14.5% prevalence of HIV amongst people who inject drugs. So the government of Kenya, the Ministry of Health through NASCOP, has done its best to provide harm reduction services in the country. And specifically, when it comes to opioid substitution therapy, they have been able to initiate 8 methadone facilities. 7 of those facilities are what we call integrated DOT sites, integrated daily observed treatment sites. So these are sites that are located primarily in health facilities. We have 2 in Nairobi, 1 in Mombasa, 1 in Kwale, 1 in Kisumu, 1 in Kiambu, 1 in Kilifi, coming to 7. Then there was 1 prison dispensing site that was initiated in Shimolatewa, making it the 8th national facility. So these clinics run not just with the Ministry of Health, but in collaboration with a number of implementing partners. So when we work with the Ministry of Health, we also work with the county, now Nairobi City County, now Nairobi Metropolitan Services, to manage the facilities in Nairobi. The implementing partner here in Nairobi is the University of Maryland, who receives funding from the PEPFAR. We also have civil society organizations, 4 of which are providing services in Nairobi and Kiambu. And these are the ones who are responsible for community mobilization, preparing the clients and referring them for MAT. So the 4 organizations we have are NOSET, SAPTA, LVCT, and Médecins du Monde. And it's important to note that the latter, MDM, has since transitioned its program out of Nairobi, and the operations are now being run by SAPTA. So we have 3 main societies providing services. In terms of the pathway to care for methadone clinics, we work primarily with a community to facility linkage model. So what this implies is the civil society organizations will conduct outreach, will provide harm reduction services. So they'll provide needles, syringes, they'll do screening for TB, HIV, and refer any of the patients who they need for InReach, provide targeted information, provide education on methadone, and then refer. Once they come to the DIC, there's a focus on the patient preparation, a lot of addiction and information counseling, and then providing harm reduction services. So if you test HIV positive, initiated on ART treatment, and then management of other infectious diseases. Those who are considered eligible for methadone are now referred, where we induct or enroll. We provide psychosocial counseling. We provide harm reduction assessment and support in line with the comprehensive package. We also do non-communicable disease management. So although this is the primary model, we've had instances where there are alternative pathways. We have had people coming in through public hospitals as well as private facilities, and Chiromo has actually referred patients for enrollment. As regards public facilities, one of the useful things to note is, although they might not be selling us a large number of people who are using heroin, they've actually been very proactive in sending healthcare workers who have opioid use disorders. So in terms of implementation, we will look at what we have done in the last 6 or so years. So between 2014 and 2016, this is when the groundwork was being set to initiate the first clinic. And so the first clinic was initiated in Mathare. Of course, this is with the Ministry of Health in Mathare National Teaching and Referral Hospital in collaboration with NASCOP and the University of Maryland. So a lot of what was done was provision of space, infrastructure adjustment, ensuring that there's commodity security, training the staff who will provide the services, and exchange visits to other sites that have provided services. So this paved the way for enrollment in December 2014 on the 8th, where the first patient was enrolled. Initially, they were working with targeting injecting drug users, but that threshold was lowered in about 2015 to allow smokers into the program. And right now, when you look at the data, the ratio of smokers to injectors is almost the same. It's 1 to 1.5. So we do have more reported injectors. We also did site preparation around 2016 for the initiation of the Ngara Methadone Clinic, which is located in Ngara Health Center, a level 3 facility. So coming to the second section of the implementation, we had the second clinic start in January 2017 in Ngara Health Center, and this was in collaboration with Nairobi City County, now NMS. And by then, Mathare had successfully enrolled 597 clients, 434 of whom were still coming daily. So that was more than 70% of the total they had enrolled. By this time, Mathare was having some challenges in terms of human resource, and they were having technological difficulties. There was a strong need to decentralize the services because the clientele had become too high. And that was the reason why inductions were suspended. So come later in the years, in 2020, the two clinics have so far enrolled 2,168, and still over 1,000 of them are active. So although this is just a little over 50%, they have done a great job in terms of enrolling as many clients. One of the things we've been able to do, and I'll talk about it a little later, is to initiate takeaway dispensing for patients who are in prisons. And recently, we are working on quantification to introduce buprenorphine as an alternative MAT. So the important thing to know about the milestones is based on the estimate, the Nairobi estimate of 2013, we are at 35% uptake, which would be considered low by many standards. But when you look at literature, access to MAT in the world stands at 30% and uptake at 10%. So if you look at it relative to that, although we are nowhere near our estimate, Kenya has done a great job, and especially Nairobi in terms of enrollment. So we've had a number of achievements. Of course, being able to reach over 2,000 people is no mean feat, and we've been able to reach 2168. We've been able to continue providing, as of September, daily treatment to 1098. For those who have tested HIV positive, we've been able to have 100% viral load uptake and 98% suppression. This is a big deal when you look at PWID, especially who are still in the community level, where viral load uptake tends to be about less than 50%, and the suppression is usually at around 60%. So the evidence is very clear that if you are on methadone, then your viral load uptake and suppression will be close to 100. We have been successful in reintegration, having more than 70% of our clients reintegrated, and there has been an 80% decrease in violence and crime since enrollment. For the mothers the women who got pregnant, we've had a total of 36 pregnancies, and 30 of them were successful deliveries. We only had 5 mothers who had neonatal abstinence syndrome, and 4 of those children are alive and well. 1 was a mortality. So the 4 were actually managed successfully with morphine. And for the mothers who have HIV positive, there's been a 0% positivity in the children. So all the children are negative, and that's a great testament to prevention services. We've also been able to provide capacity building on HIV, on non-communicable diseases, GBV, and addiction management. We also still have some other successes along the lines of data management and reporting. We've been able to initiate point of care services in Ngara MAT Clinic, which is probably one of the first clinics to successfully, methadone clinics to do it. And we are on our way towards doing the same in Mathare. So when the COVID pandemic began, our biggest concern was we do not want relapse. We want to mitigate it as much as we can. We want to mitigate overdose risk. We want to reduce the risk of people going back into crime, increasing the risk of violence and incarceration. So our main objectives when we're getting into the pandemic was to ensure daily access, continue daily access to MAT, and of course to promote not just patient, but also staff safety during the provision of the services. So what we did initially, because we did not understand the pandemic, we suspended enrollments, meaning no new patients were coming in. We also suspended what we call reinduction, so patients who had dropped out from coming in. As we were awaiting the government directive and the government policies, we quickly developed clinic level SOPs that covered screening and identification. We looked into referral. We looked into infection prevention and control. We looked into staff and patient well-being, as well as psychological first aid for staff and clients. We also opted to view things in the context of essential versus non-essential services. So we did some temporary task shifting with what we considered to be temporarily non-essential services, supporting essential services such as dispensing. And then when we identified some positive cases in the clinics, we ensured that we were able to do mass screening of all the staff and the patients. We were able to, so what has been happening with people in prison, they have been they're brought every day to the clinic. So of course, when the pandemic started gaining traction, We opted to initiate fixed dispensing, meaning we pre-pack the doses and we take them to the clinics and they are dispensed there as opposed to daily delivery. We also engaged in private-public partnerships so that we could support with securing infection prevention commodities and PPE, because we remember at the beginning of the pandemic, there was a heavy shortage of PPE. We also engaged with area chiefs so that we could get letters for those who had been locked out of Nairobi. So this is when you remember the Nairobi lockdown, anyone in Kiambu and its environs could not come in. And then there was a point where Isili was shut down, so no one could go in or out of Isili. So we were able to engage with the chiefs to ensure that our clients were provided with letters, and we were able to do this for 35 clients. We also tried to ensure that we could get patients transfers for those clients who are residing perhaps in Kiambu, where we now had a newly established clinic. We were able to facilitate transfers. We also had a few who were able to make it to Mombasa, so we initiated some temporary transits, although the transits are not included in this data. We provided linkage for GBV services due to the increased violence risk. So our population is very mobile, very dynamic. They are the ones who are likely to be touting, they are likely to be hawking, and they are likely to be out after curfew hours. So it was highly likely that the risk of GBV from City Council or the police would be higher. So we provided linkage for that. And then of course, we provided pre and post debrief sessions for the staff in the clinics based on the national protocols that were developed. So if you look at what we considered essential versus non-essential, daily dosing was considered essential. So were clinical reviews, emergency as well as emergency psychosocial reviews, and emergency linkages. What we temporarily referred to as non-essential was now the client preparation, induction, and reinductions. We temporarily suspended quarterly retesting because of our concern about infection risk, and we suspended group therapy sessions and support groups. So the successes as a result of this, we were able to retain 90% of the people who were receiving services at the beginning of the pandemic. So the end we had by perhaps the end of March, we were able to retain most of them as at September. We were able to successfully have inter-county collaboration so that we can make sure there's seamless patient transfers and seamless patient movement to the clinic. We were able to ensure commodity security. So Dr. Njenga earlier mentioned that there have been shortages in Mathare. Within the methadone clinic, we did not run out of methadone. We did not run out of any other essential medicines that were required for management of our clients, be it for withdrawal, overdose, or other medical conditions. We were also fortunate enough to have a 0% identified COVID positive amongst our MAT clients. This is as at the time that we tested. And we were able to receive a lot of support to implement the above from Mathare National Teaching and Referral Hospital through Dr. Jumba and now Dr. Mwamukoma, as well as the NMS to support with the testing. So this is one of the successes, our grandest successes of COVID. We were able to, so how this actually happened is once we started identifying positive cases in the methadone clinics, the prison wardens were reluctant to come because they were reluctant to be exposed. So they declined to bring the patients, but they offered transport for us to take methadone. So what we opted to do is conduct a site assessment. We reviewed the facility, had discussions with the in-charges, and then began with daily dosing. So we would pre-pack and take daily. Once we assessed the systems and so the systems were favorable, we started to stagger the delivery of the doses to twice, every 2 days, and then we were able now to titrate it to weekly doses. So at the moment, we're able to pre-pack weekly doses, and we have the support of the prison team by them providing the transport. In terms of prison dispensing, when we look at the total, the numbers that we were able to dispense per month since we began the dispensing, first of all, we were taking this to remand prison as well as Thika prison. We were able to dose 15, 14, 13, and 11 between May and September. And these look like small numbers when you look at the grand picture of over 1,000. However, when you look at the number of doses that we have to prepare and the work hours that are required to dose this kind of people, then it starts to put a good case for having fixed site dispensing. So we were able to prepare an average of 94 weekly doses and more than 410 doses. And those actually account for 13 workman hours. So this is data that would be very useful when you're doing cost effectiveness analysis for scaling up prison site dispensing. This is important to note. These were only 2 sites, so this does not take into account people who were actually arrested and were in jail. So we have 75 that are documented from one health facility, but there's some data that is missing for another. And so this is something that we would want to consider in terms of dispensing as well. It's important to note as well that majority of these people were actually arrested, the daily arrests, for curfew, walking outside curfew hours, touting, and hawking. We also had a number of challenges. So despite our best intents towards providing IEC, putting in the social distancing and all the recommendations, providing IPC, we still had a 5% COVID-19 positivity. This is amongst the healthcare workers. So although we reported 0 amongst the patients, we still reported some positivity amongst the healthcare workers, and our suspicion is around community transmission. We also unfortunately had 2 HIV seroconversions. So these are people who had been on treatment for perhaps more than a year and came in negative, have been negative on retests, but turned HIV positive. The seroconversion prevalence for that is actually 0.002. We had a lot of challenges ensuring staff safety in terms of screening, because this is a high volume facility with many clients coming in, poor following of the regulations. We really had a difficult challenge ensuring safety of security despite providing PPE. Of course, there was a shortage of PPE. There was a lot of stigma towards our staff as well as towards our clients. There's a perception that we are a very high risk population, and that stigma resulted in negative experiences. There was a lot of apprehension amongst staff around the COVID pandemic, the measures that we are taking to protect them, and the general risk. Of course, we, as a result of trying to understand this pandemic, we really had to reduce our alcohol screening or our use of the alcohol breathalyzer. So one of the major challenges we had is actually the reduced vigilance for high-risk alcohol users. So we had to rely on clinical suspicion as opposed to a more objective measure like the breathalyzer. Then, of course, and I'll show you attritions. We did have a number of patients who relocated from Nairobi during the pandemic. So just to look at the attrition specifically, and this is paying attention to March to September, we happened to lose 165 clients from the 2 MAT clinics. The largest proportion of those, 89%, are actually patients who we refer to as lost to follow-up. So these are people who dropped out of treatment and we have not seen them for 30+ days. Now, the reasons behind that could be varied. There could be a number. It could be relocations, it could be relapse, it could be a combination of factors. We also had a few that transferred. I think I mentioned that. We experienced about 4 mortalities, and the mortalities were as a result of heart attack, colon cancer, 1 with mob justice, so that's crime, and there was a suspected overdose. We also had people who had what we called self-discontinued, meaning they had been on treatment and then opted, they were on cessation, meaning gradual reduction. And when they got to a minimum dose, opted to stop treatment. And then there was 1 who had actually completely been weaned off. So we had 4 clients who had previously been off treatment who came back during the pandemic. And then the interesting thing is the loss to follow-up does not account for patients who may have disappeared but went on to be re-enrolled in another clinic, in the other clinic in Kiambu. So in terms of data use, we do have some limitations because there's a lot of missing data over this time. So for example, the people who are lost to follow-up, at this point in time, we are yet to establish how many of them have actually relapsed, how many have died, are there overdoses, are there people who've actually had a cold turkey recovery. As at the time when I was preparing the presentation, I did not have data for Ngara Mat Clinic to show those who are in jail. So the number 75 is actually a lower estimate. We also do not have data on people who have opioid use disorder who are in prison but not on MAT. So our dispensing was only for the patients who have been receiving methadone, but not those who had not yet started. So that means there was an opportunity to provide methadone for more clients. We also don't have data on the socioeconomic effect of COVID on our clients. Remember, these are clients who rely on what we call a daily hustle. So the lockdown and the restrictions must have had a heavy impact on their socioeconomic status, but we do not have that data at this time. We do know from anecdotally and some of the data warehouse reports that there's an increase in violence for people who use drugs and people who inject drugs. But at this point in time, we still do not have GBV data on the effect of GBV on the people who are on methadone. And then of course, because of non-essential versus essential services, we are yet to put together information on the impact of COVID-19 on mental health, specifically alcohol use and abuse, depression, and specifically mood disorders, because these are the most common comorbidities that we are managing. But in light of that, we were still able to identify some future directions for MAT service delivery, and these are fourfold. So the first is in terms of scaling up alternative service delivery models. At this moment, we are relying on a daily observed model, which can become non-ideal in a pandemic that requires a lockdown. So we are highly advocating for the decentralization of MAT services through fixed dispensing and perhaps mobile services, mobile sites. We are really advocating for the provision of take-home dosing, of course, in line with the PPB regulations and where it's safe to do so. We are very interested in the scale-up of buprenorphine as an alternative because it works very well for people with moderate opioid use disorder and is very amenable to alternate day dosing, meaning clients do not have to come every day. Of course, we would like to support any national initiatives on disaster preparedness. So we were proactive in coming up with clinic level SOPs, but supporting the rollout of national level SOPs, especially for MAT. And then because we do have a large number who are jailed and end up missing their treatment, then it would be important for us to identify a jail where identified PWID can be transferred and can be retained there and continue to receive their services. So I think this is a collaboration perhaps between NASCOP and the law enforcement to see how this can be effected. We have had some moderate success with the prisons where we've been able to have them transferred to a specific facility where they can facilitate dosing. In terms of patient and staff well-being, of course, continuing to ensure that there's adequate PPE for clients and staff because that promotes that psychological sense of safety, continuing to provide weekly debrief sessions to mitigate burnout, which we have done our best. In terms of provision of services, of course, if you look at 165 lost in a few months, then it's really important to expedite the resumption of normal service delivery in line with the MAT programming. And then, of course, because we have had seroconversions, we need to mop up the HIV retesting because there's a probability that drug use patterns changed over the pandemic. So maybe there could be a risk of needle sharing and maybe a risk of HIV seroconversion as well as transmission of hepatitis C. So we really need to remove that. We also really need to trace the people who disappeared during treatment because there's probably a proportion who have relapsed and would still benefit from the services. And then because we have seen task shifting worked, we need to come up with a system that can allow for task shifting because one of the biggest challenges we have in methadone service delivery is the human resource. There's a perpetual human resource shortage. So ensuring that multiple cadres are able to provide roles across the board seamlessly. Then finally, there's a great opportunity for research over this period. It would be nice for us to know what impact COVID-19 had on drug use patterns, on overdose risk. We did not have any overdoses reported within the clinic, but a lot of overdoses happen in the community, like the one I mentioned. So it would be nice to know what that looked like. It would be nice to do some research on HIV seroconversion rates. And then, of course, because we have a little bit of information based on preparing doses for fixed site dispensing, we have data on the time it takes, the dosages that were required, the human resource personnel required, so we can compute the workman hours and the amount it would cost for the human resource. We can actually do some cost effectiveness studies so that we can put in a good case for fixed site dispensing, both in prison and in jail. Then of course, because we are yet to put in some data on mental health, it would be nice to do some research to see what impact COVID-19 had on the mental health and the socioeconomic outcomes of the people who are on methadone treatment. And there ends my presentation. Thank you very much.